has two openings right here for the ureters, and then an outlet for the urethra. This area here is called the trigone. Embryologically, it's different than the contracting part of the bladder. This does not contract. It's very apparent. When you open the bladder next week, when we do the pelvis and perineum, you'll find the trigone. It's easy to find. Okay? Again, that's a next week deal. Innervation of the bladder is also next week, so don't even worry about this. Other than to say, there are a couple of things here. You have a voluntary and an involuntary sphincter of the bladder. If you got to pee right now, it's your voluntary control over the somatic diaphragms that's keeping you from peeing on yourself. To pee, you shut off the sympathetics, which opens your urethral outlet. You fire the parasympathetics that contract your detrusor, or the contractile part of the bladder, and that's how you pee. You have to do all three. Relax this voluntarily, relax your sphincter autonomically, and contract the bladder autonomically. Suprarenal glands, you have one on each side. They're sitting on top of the kidneys. They're within the renal fascia. There are two broad parts to the adrenal gland. There's an adrenal cortex and the adrenal medulla. The adrenal cortex, this thing is an endocrine gland. The adrenal cortex secretes three different types of hormones that regulate fluid and electrolyte balance. They have sex hormones and another hormone that regulates steroids, glucocorticoids that help with affect the immune system and sugar balance in your system. And then the adrenal medulla secretes norepinephrine and epinephrine that's responsible for a lot of the fight or flight adrenaline response. Okay. You can look at it. Aldosterone I mentioned this morning, right? That's where the renin system goes, aldosterone. Here's the glucocorticoids. I forgot this slide was up here. And then the sex hormone, the androgens. So from the outside in, it's salt, sugar, sex. Salt, sugar, sex. Those are the three layers of the adrenal cortex. Salt out here, aldosterone, cortisol, and testosterone, androgens, we'll say right here. This is the adrenal medulla. Huh? The arterial supply of the suprarenal gland comes, because it's such an important endocrine organ, it has a huge blood supply, both on the arterial and the venous side. It's on the arterial side, it's supplied by three arteries. A branch off of the inferior phrenic, a branch off of the aorta, and a branch off of the renal. So you get a superior middle and an inferior suprarenal artery. The suprarenal, it has one large vein. The suprarenal vein typically will drain into the renal vein. Let's go with the renal vein. It goes into the cable system, most importantly. The autonomics of the adrenal medulla. Now, the adrenal cortex is hormonally controlled, mostly. The adrenal medulla is innervated by the thoracic splanchnics. Splanchnics are predominantly preganglionic, right? They send their, if they're not going to synapse into chain ganglia, they synapse into pre-aortic ganglia, right? The adrenal medulla is an exception. The adrenal medulla actually acts like a pre-aortic ganglia. So here's the preganglionic fiber goes all the way to the adrenal medulla and synapses in the area of the adrenal medullary cells. Which in turn dump out epinephrine and norepinephrine.
What did you say those cells were called?
These things right here, just say adrenal medulla. They're actually called chromatin cells, in case you're on Jeopardy. But just say adrenal medulla. We'll go over the specific cell types in pathophysiology when we get to adrenal glands. And you can call them adrenal glands or suprarenal glands. I don't care which. You find them, if you find the superior pole of the kidney, they sit right above it, and they're shaped like pyramids. They're about this big. They're more or less about that big. And they're kind of flattened. So they look kind of like pancreas tissue, which is glandular tissue, and they sit right up there. And they're highly innervated and highly vascularized, owing to their nature. Who was the one that met Bob Neal? You met Bob Neal. His wife Lily died of a suprarenal tumor. That was what killed her. If you look at this picture here, and as you read these things and what they are, you should be saying, oh yeah, that's what that is. Oh yeah, I understand, Okay, this is sort of a summative slide you should be able to comprehend. Now, on the... Okay, it happening. On the posterior abdominal wall, there are a series of the lumbar plexus. Just take a look at these today. We'll dissect them more later on. You will see the cruise of the diaphragm here, and the lumbar plexus is here. We've already seen the ilioinguinal and iliohypogastric coming off of L1. The genitofemoral sits on top of this large muscle called the psoas, very easy to find. The large femoral artery lies under the psoas. There's one that crosses the iliac crest here. That's the iliacus muscle. It's a flexor of the hip. That's called the lateral femoral cutaneous nerve of the thigh. We don't care. There's a muscle we're going to find, a nerve we're going to find next week. Two of them, actually, the lumbosacral trunk and the obturator. These guys come off of the lumbar plexus. I think there'll be enough to tag without having to get to the posterior lumbosacral trunk, but you need to be aware of these nerves because a lot of the radicular pain from lumbar degenerative changes to the spine travels over these nerves. Understanding, of course, that the nerves in the abdominal wall are just like the thoracic wall, they travel between the two innermost layers of muscle. Here they are once again. I don't even know why this slide is in here, but that's sort of a summative. The two muscles you'll see today on the posterior, the three muscles you'll see today on the posterior aspect are the psoas muscle, rises from the lumbar vertebra. It will join the iliacus muscle, which arises from the ala of the pelvis here, to insert is a single tendon into the proximal femur. Very strong flexor of the hip. Beside it is the quadratus lumborum that I mentioned the other day, arises from the iliac crest, inserts into the lower ribs. It's responsible for a lot of that flank pain when you pull and overstretch your muscles. The diaphragm we mentioned yesterday, you should be able to find those crura recognize those. I saw one yesterday. Finally, renal stones, renal calculi develop in the collecting system of the kidneys, namely the minor calyces. They can travel into the major calyces and into the ureter. They can be tiny, tiny renal stones. Most of them are calcified. They can be pretty large. As they squeeze through the ureter, they usually rip the mucosa and cause bleeding. So painless hematuria is a sign of renal calculi. Painless hematuria is a sign of renal cell carcinoma. Painful hematuria is a sign of renal calculi. Painful. Hurts when these things go tumbling through there. Painless is a sign of renal cell carcinoma or bladder cancer. Interesting, your kidneys start up here and descend. So that when the stone enters the pelvis, the renal pelvis, the pain is up here in the CVAs. Then as it goes down, it starts going more inferiorly and wrapping around until it gets down there next to your bladder. It's wrapped around so it's in your labia majora or your scrotum. The pain is, oh my gosh, like that, until it boop, pops out into your bladder, and then the pain suddenly gone. When you transplant a kidney, you don't actually take the old one out. You just leave it there. Take the new one, and why get up here and start messing around all this stuff up here, all these big arteries and vessels, veins up here? Let's just go down to the pelvis, where you got tons of room, and we'll suture it into the iliac vessels. Right there. We'll just stick it down there. That's what you do. You put a transplanted kidney in your pelvis. Yep, that's cool. You know how your testicles and your ovaries, mostly the testicles, well, they're more interesting in terms of their travel. They start up here. Remember I said the gubernaculum pulls them down there? Right? Your ovaries just make it to the pelvis. Your kidneys do the exact opposite. They start down in the pelvis and go up. And some people, they don't go up. And you wind up with pelvic kidneys. The kidneys are in there, one or both kidneys is in the pelvis. In some people, the right and left kidneys confuse, and they form a horseshoe kidney. Over here on this side, you've got the ureter wrapping around the inferior vena cava instead of staying on the same side. My wife only has one functioning kidney. Didn't know it until she got worked up for something, and she's only got one functioning kidney. The other is just a little rudimentary ball of gunk that doesn't do anything. That's interesting. I mean, not for her, because she only has one kidney.
Is there a specific muscle that helps the kidneys travel up to where they're intended to be?
There's nothing that pulls your growth.
Okay.
Is what, and sometimes, here's the other thing that's really significant is that you got to watch out for the renal arteries, because when you started out, the artery going to your kidney was down in your pelvis, and then as it ascended, it picked up a new artery, and this one degenerated. Then as it kept going up, you pick up another artery, and this one will degenerate. In some people, it doesn't degenerate, and you wind up with the renal artery coming off of the iliacs. So it can be really screwy. You know, like I say, don't take everything for granted, the anatomy for granted when it comes to the urinary system. When you start poking around on, you might in 1 out of 10 people, you're gonna find something that ain't right.
Where do cysts usually, like for polycystic kidney disease, where do they usually?
Cystic disease involves the renal parenchyma itself. The cysts can be so bad, as they grow, they push against the pyramids and destroy the normal renal function. And so polycystic kidney disease they usually wind up on dialysis or a transplant because of the progression of the cyst over time. When we cut into a kidney today, I want you to cut into a kidney. Take a kidney out and cut it right longitudinally and open it up and be able to see the pyramids and column. We'll probably see some renal cysts today.
What do we do with these horseshoe guys?
Usually nothing. The only time it becomes a problem is if there's hypertrophy of the kidney and it puts pressure on the vessels, especially the inferior vena cava, but that rarely happens. Usually it's just something you find at autopsy or when you were looking for something else. This is something you don't want to run into. This is called an abdominal aortic aneurysm, or AAA. Can I get you, Kayla, to get up here on the thing, put the light down? So, one of the things you want to do when you're doing your physical exam is you want to palpate the aorta. And so to do that, can I pull your shirt up to right there? All right, to do that, so come up here because you're going to do it. Tuck that. All right. What you don't want to do when you palpate an aorta is to just stick your hand on it. Okay? If you were to do that to that big fat aneurysm up there, you see where the aneurysm is, right? You're going to pop it. That's not good. When that thing bleeds, you're usually DED, dead. So what you want to do is, when you feel for the aorta, come here, move this way here. What you want to do is gently take your finger and start way out wide, because the aneurysm may be out wide. And you're feeling for the pulse of the aorta. And what you want to do, is the aorta on the right or the left? The aorta should be right about there, right? So you want to start walking your fingers towards each other, pushing down gently until you feel the pulse of the aorta. Now look right there between my fingers. You see her skin bouncing? There's the pulse of her aorta. Now put your fingers right there. You can see her aorta is about that wide.
My hands are cold.
Come on down. Anybody come down? So on a slender person, it's pretty easy to palpate. That's how you feel an aorta. You come in slowly from the side. Don't just stick your hand on it. Like this guy's doing in the bottom right. That's all we're going to talk about for the second test.
That's it?
Yeah, that's all.
For now.